Well, we've got about 14 minutes for discussion, but Kevin, I wonder if you could just make a few comments about next steps for you, because I look at this as a chance to see some very interesting results and maybe shape your next steps.
So the very next study that we are doing is a large national survey of adults, and we're designing that right now. And I think besides trying to clarify some of the things we found in the qualitative work and some of the things that you guys and other people found too, and try to get check out the consistency of results when we use different sampling methods. We would also like to focus on how people perceive appeals to do this kind of research and what influences their perception of the acceptability of that research. That was something that we were able to touch on in the qualitative work, but we didn't really get to dig into that as much. So I think that'll be the main focus of the quantitative survey. And then following that, as I mentioned, we will be doing interviews with different stakeholders, especially people who are involved in oversight of human subjects research, to present summaries of our work to them and to find out how they think the system of oversight might be altered, if at all, to better accommodate the interests that we've learned about. Is that enough detail?
It's a good start. I love this stuff. I have 1,000 questions, but we ought to, I've already had a chance to see some of this. It'd be great to get some audience questions.
For the West Coast branch of the study, were there any differences in terms of preference for notification according to age or socioeconomic status, or education?
Yeah. Again, I have to look back at the slides, but in general, I think age and socioeconomic status were correlated with a higher or more stringent notification preferences and lower amounts.
Yeah, that's right. And given that our sample oversampled people who are more affluent, we probably underestimate the degree to which people are willing to have a lower notification standards.
Yeah, this was for Ben, especially in terms of the survey. It was interesting to me because a couple of years ago we did some surveys of constituents of the Depression Bipolar Support Alliance. It's a big national organization of people who live with mood disorders. And we were specifically focused on their preferences about consent for medical records-based research, not interventional and not randomized research. But a remarkable similarity in that we laid out a series of scenarios that at least we perceived as, in the general scheme of things, falling in very different places on the risk and the feasibility spectrum in terms of getting informed consent, ranging from, say, a study that would just compare aggregate suicide rates across health systems for 10 million people, and a study where an individual would be reading the notes of your visits with your doctors to find out things about your mental health care. And so we asked people across these different scenarios what their preferences were in terms of the need for written informed consent, and observed zero difference. So it was interesting to me to think about, does this mean that we just did not accurately communicate what we were trying to communicate in terms of the differences between the scenarios, or are the things we think are important people don't care about?
I think we probably both have comments on that, but I think that I'll start by saying I think that what we learned was that people, they're really curious. They want to know stuff. They would love to, and they think it's a good thing. In fact, I would describe in our focus groups that people said, we think medical record review is going on, we think data sharing is going on, but no one ever tells us. But we really hope it is, because we think that's really important. And so I think that part of them wanting to know is not that they want to give permission, but they want to know about this because it matters to them that it's happening.
I'll just add that one reason why I I think we're actually not, it's not just a miscommunication, it's really, they really are getting it, and this is really, we're finding out this is how people look at it, is the fact that even though the vast majority support doing research when there's that conflict, you do see a little bit of movement in the size of that minority when it's randomization and medical record review. So their initial preferences are basically the same across the board, and the vast majority want the research to go forward anyway, but the size of that minority does bump up. And so that suggests that they are getting it. It's just that they don't look at it the way that we do, the way that IRBs look at it, the way that the regulatory system looks at it. They wanted for physicians to talk to them about things. And so if we're going to go forward with a learning healthcare system model, what we really need to do is have physicians talk to their patients more about what's going on and what kinds of things are being done. And that probably is going to matter more than having consent forms that lay out a lot of these different risks as put forth in the guidance.
It's great. The mics are warming up. I like this. So I presume we can go a few minutes over if we need to answer questions about the research. And again, we'll have time tomorrow to talk about the meaning of this.
Hi, just a quick point of discussion on the ROMP study. First of all, thank you for doing that. Actually, both of these studies were very nice and informative, and I appreciate them both. On the ROMP study, I'm a little bit concerned with the characterization of it being a vast majority of people who are okay with going forward. And I think in the context of a political election, 75% or 30% is overwhelming, and you talk about mandates and so forth. But in the context of clinical research, where informed consent is so important, and personal autonomy is such an important concept, I wonder if instead of thinking about 75 or 70% of people saying go ahead without the consent as being a vast majority, maybe it makes sense to think about the 25% or the 30% who say, whoa, not so fast, as being a substantial minority who would say, even though 75 or 70% would say, go ahead and do this anyway, if 3 out of every 10 people are saying, no, I want to give consent, what that means in the context of personal autonomy.
This is something that Jeremy and I have had so many discussions about this, is what's the proportion of, if autonomy is the totally dominant American ethical principle, is it 1%, is it 2%, is it 30% that it takes to say stop?
So, and again, going from what people want to policy is tricky. But what we're trying to capture is something about the relative values that people have. And I think what our data, in a way, the data speaks for itself. I think it is true that, maybe it's framed by election data, but most people, the values that most people and most patients have, research really matters to them, and they value that. It is also true that, as you said, there is a substantial minority, and that minority is slightly bigger, that say it shouldn't go forward. But there's also that minority there even for medical record review, which right now is seen as largely unproblematic and done without consent on a routine basis. And so I think we have to frame that, even that minority, by acknowledging that exists there. So if we're trying to capture what people value and people care about, I think this goes a long way towards getting at that, even if there's, of course, not universal agreement.
I'll add one more thing. Again, our project, one of our approaches was not only to do the quantitative studies, but also to follow them with interviews. And that's exactly one of the types of questions that we would want to ask for those people who were concerned about not doing this without informed consent. Having a conversation rather than just filling out a survey and saying, well, in that situation where this is difficult, how would you feel about this? And really trying to explore that in more detail.
Hi, Nancy Roach, patient advocate. And this was really interesting to hear because it was like the first thing that people said all day that actually resonated with my experience as a patient and a caregiver and someone who deals with people every day. And so what my question is I wonder if the three of you have talked about some of these results with IRB folk at your institutions, and if you have, I'm just wondering what the IRB folk thought about this, because I really do think there's a paternalistic or maternalistic, depending on your perspective, attitude towards protecting patients on trial.
I'll respond to that because we did some of our initial focus groups with our IRB at the University of Washington, and trying to fulfill on the promise of returning results to research subjects. I gave a presentation to the Human Subjects Division about a couple of months ago. There were like 40 people in the room. They were very excited, very energized, very intrigued, and I would say that they talked about the conflict between what their views might be and their interpretation of the regulations.
That's a very interesting statement, and we're going to come back to that tomorrow, I have a feeling. But there is a little meeting called Primer coming up. Are you going to present these results at Primer?
Yeah, Sandra is, so one of our teams.
I think we all should follow the response to that, because you'll have, that's like the ultimate IRB convention, I guess.
Quick question. I was intrigued by the difference in the responses between Primer members and the general public, and a lot of it seems to turn on the information that you gave people about what ROMP is. I'm sure you tried to be as unbiased as possible. Do you think those cartoons would have been different if Primer members wrote them?
I can't answer that. But what I would say is that the process of writing them did involve vetting them with focus groups and getting input from patients and doing that. The scenarios, though, that were presented for the Primer survey and the patient survey were very similar to each other.
Yeah. And just one thing, just to be very clear, the videos and the comics that we've used were for the patient surveys and focus groups, not for the Primer ones. So the Primer members in their surveys saw Scott's scenarios, but we figured we didn't need to explain what if we had to explain what randomization and medical record review were to Primer members and IRB members, then obviously we'd be in a much deeper problem than having anything to do with our guidance.
But another version of that question to you all would be, were there IRB people involved in vetting what went to the patients? So you did include IRB.
Yeah, and actually the chair of the Seattle Children's IRB is one of our consultants for the project.
As well as Alex Capron, who's the president of Primer, is also one of our consultants. Yeah.
Yeah, fascinating data, thank you. One of the things that I noticed that was very striking is that there was a big impact of patients wanting to know and not be blinded. And of course, that's one of our other core beliefs, is that it's valuable to both blind the clinician and the patient, but it does seem to have substantial impact on how patients feel about this research. I'd be interested in your comment.
Yeah, I mean, I'll comment on that, particularly from regards to the focus groups, because that really was an issue for people. I think for them, and it relates almost to what Kevin was saying too, the idea of blinding is really what troubles people, not knowing what's going on. They have no idea to the assignment being done by the gumball machine or by the computer, by the flip of the coin, but they do want to know what's going on. That feels more like what typical practice is, and for many people, that was that really mattered to them, as well as their doctor saying, I think this is a good idea for you to do this. And I think that's, to me, the most interesting point, because we normally think that when we present research, we shouldn't be making recommendations. But what we heard from patients was that they want a recommendation, and we challenged them and said, well, isn't that a problem? And their response was, look, our doctors make recommendations to us all the time. If we don't want to do it, we don't do it. But we want to know what they think.
I'll just add one other thing that makes it complicated to interpret, which is, the patient focus groups in particular, these are all people who have a lot of experience of the healthcare system. So they're aware that there's variation in different drugs. They have a lot of trust, but one of the reasons why they want to be told is because they were saying things like, yeah, I know there's different drugs, and I want to know because we've already gone through 3 drugs, and that one didn't work, and this one had really terrible side effects, and I don't want to be randomized to one of these drugs that didn't work. So I, of course, want to know so that they can not give me something that I know didn't work. So so that does make it sort of complicated in assessing the results from our qualitative studies, and getting very clear about what you mean when you say that you know and why is really important to interpret the results of the studies.
Maybe I'll just add, we had maybe a little bit of a different experience, may have been different populations of folks, but people did react very strongly to the idea of their treatment being determined by randomization as opposed to the doctor. So that was something that people really struggled with and had an emotional reaction to. And even though in the abstract, at the beginning of our groups, everyone espoused the importance of trying to reduce uncertainty about effective treatments and that research was the best way to do that, a lot of people reacted very strongly to the idea that their doctor really didn't know the best drug to give them, and so therefore randomization was going to be something they'd propose. So people really struggle with that in our groups, and maybe because we had people who were less sophisticated with respect to research, but.
How much did you drill down on the increasingly blurry distinction between high-quality, quality improvement activities and clinically embedded research? I mean, I heard aspects of it in both of your activities, but it seems to me it's critically important for the overall conversation we're having.
Well, you maybe should be answering that one. For us, for the patients, we didn't at all. We did with some with the focus groups of the IRB members and the Primer members, and we decided to focus on these topics because these were most salient to the guidance. But there's also going to be another paper and other results about that issue about QI and the blurring of that line, because we definitely saw issues around that in the Primer and in the IRB focus groups.
And while we had scenarios that had to do with medical center operations and cluster randomized trials of those, for all of our scenarios, we consciously avoided using language that categorized types of studies. We stuck to talking to the patients about what was being done, under the assumption that what we wanted to do was to find out how patients experience these, how do they think about them, and we all in a different room can figure out what we want to label those things. And so we didn't get into those distinctions with them. We talked to them about different types of activities.
It would be terrific when you lay out your results if you make clear that they apply in a way equally to activities that we call research and activities that we call quality improvement.
I mean, it seems like there's another trade-off here, and I'm cognizant of time, so I know we've got two more people up, but I mean, the one trade-off you depicted was that the research couldn't otherwise be done. I mean, another is if there is aversion to blinding or to randomization, I wonder if it were framed that the research would be less likely to get a valid answer, whether people's views would be moved at all. Because I mean, one of my great worries, as I watch a lot of QI going on now, there is some creep to saying let's call it QI because then we won't have to go through the IRB and people won't question what we're doing. Steve?
So it's great to see some empirical research, and I don't think I've ever before said people need to do more qualitative research, being a quantitative reductionist. But it would seem that in these designs, and I know you said you've interviewed some people afterwards, you really don't know very much about what people's perception of risk is, and the way you've worded the questions, you didn't ask somebody if you were uninformed and you were in a study and something bad happened to your mom, how many lawyers would you call? So I think it's really important to follow this up and really, funding permitting, to go pretty deep in people's understandings. I don't think you're saying that because people prioritize the research, we should, in any way be derelict in protecting individuals. I think that needs to be said. But I do think there's some interesting larger issues that unfortunately will go well beyond the narrow purpose of this conference, but it puts me in mind of two things in terms of context. One is some years ago, somebody in the FAA got the idea that they should, if you had an infant, you shouldn't have the infant on your lap, you should buy another seat and have a car seat. And ultimately, they didn't issue the regulation because somebody did the analysis that more people would drive, and driving is much more dangerous than the risk of flying in the air. Conversely, and nothing against anyone from the FDA who's here, the black box warning that was put on antidepressants because of what turns out to be a real but very small risk, but real, of increased suicidal ideation, the clinical trials have been too small to actually see any completed suicides, led, what the black box said was very reasonable. This is why the FDA, they weren't wrong. It was that you have to look at your patient. If you prescribe an antidepressant, you have to educate the family. You have to observe the patient. But what happened, in fact, is that less antidepressants were prescribed. And it's too early to make a big deal out of it, but actually suicide rates have climbed since the black box warning. So the issue really is you have the narrow responsibility of OHARP, the narrow responsibility of, say, FDA to look at safety and efficacy, but then there's the broader public health issues. And I think the kind of research you're doing, in some sense, informs this question of the ethical question of our priorities and our values. And I would urge you, beyond this, we have to deal with what the issues before us, but to think of writing about, instead of saying just safety and efficacy, the broad public health, or in this case, instead of just individual protections, American values beyond a few small focus groups and the value of the research enterprise. Somebody here didn't give me permission to say it, but pointed out that in the trial that must not be named, it would have been nice to have the results 20 years ago, because it would have saved a lot of kids. And you have to, right, so it's finding this right balance seems to be what's really critical.
Thank you for that. And the last word.
The last words are two, and it's thank you, because as a patient, I can tell you that the data, to underscore what Nancy said, that you just presented is exactly what we've been trying to convey today and in the past. And I will also offer, if you added a peer, which was mentioned this morning, a peer intervention or notification in there, those numbers would skyrocket. And I have the data. I ran YME, National Breast Cancer Organization, for a little while. And we had a specially trained peers and advocates on a hotline 24/7 to work with the I-SPY 2 trial, which was a really difficult trial to consent. And they were trained specially to talk people through it, not to consent them, but to answer those questions that they had. But there were several IRBs that wouldn't even let us do that. So there are issues here that aren't necessarily patient protected, but you should think about including the peer-to-peer part in there, and there's a lot of people who can help.
Okay, with that, I guess we'll conclude this session, but tomorrow we'll be back with some more data and time to discuss what it all means.
And you're going to put it together overnight for us? So thank you, everybody. We start again tomorrow at 8. I've asked the IOM staff, they deny that you've been randomized to a caffeine and food-free day to see whether you learn better. But I think I would advise you to come well-nourished and well-caffeinated, and we will start promptly at 8. Thank you very much.